Right. Well, I'm going to talk to you about nutrition in pre-dialytic diabetic kidney disease patients. Now, diabetic nephropathy is the leading cause of end-stage renal disease, and despite advances in optimal management of diabetes, like better blood pressure management, renin-angiotensin system blockade for patients with overt diabetic nephropathy and reduced GFR, diabetic nephropathy still remains the single most common cause of ESRD and a major contributor to morbidity and mortality of diabetic patients worldwide. Existing therapies retard the disease progression but do not prevent it. The textbook definition of diabetic kidney disease is the presence of triad of albuminuria, hypertension, and declining renal function in patients with diabetes, but not all patients with diabetic kidney disease have albuminuria. Challenges in the management of diabetic kidney disease are controlling blood glucose, blood pressure, and dyslipidemia. Now, the terms diabetic nephropathy and diabetic kidney disease are often used interchangeably. Diabetic nephropathy is the classic term used for disease caused by hyperglycemia affecting the glomerulus. Diabetic kidney disease is an umbrella term that includes the disease outside the glomerulus. It is increasingly recognized that extraglomerular lesions are seen in diabetic kidney disease, particularly tubulointerstitial lesions such as tubular atrophy, interstitial inflammation, and tubular interstitial fibrosis. In addition, renal artery stenosis, ischemic nephropathy, and cholesterol emboli syndrome may occur in a patient with diabetes. So the most important and prominent established risk factors fall under three categories. The susceptibility, that is age, sex, race, ethnicity, family history, smoking. Initiation, that is hypoglycemia, hypofiltration, and acute kidney injury. And progression, that is hypertension, dietary factors like high protein diet and obesity. Now, it was Brenner 20 years ago who identified glomerular hyperfiltration as key mediator of progressive kidney disease damage caused by a variety of initiating injuries, including diabetes mellitus. Elevation in a single nephron glomerular filtration rate in response to a reduction in functional nephron number depends on increase in glomerular pressure, plasma flow, adaptive reductions in preglomerular and postglomerular arteriolar resistances. So progressive kidney disease is characterized by glomerular hyperfiltration and albuminuria. So the diagnostic criteria of diabetes mellitus is occasional plasma glucose value of more than 200 milligrams per deciliter, fasting plasma glucose of more than 126 milligrams per deciliter, and oral glucose tolerance test of more than 200 milligrams per deciliter. Now, what is happening at the molecular level in these diabetic patients? Hypoglycemia, we know, leads to increased glycolysis and mediates renal injury in diabetic nephropathy via multiple molecular mechanisms like induction of reactive oxygen species, increasing oxidative stress, which requires antioxidant therapy, inflammation, upregulation of TGF-beta 1, and activation of fibroblasts, which requires targeted anti-inflammatory therapy, activation of angiotensin 2, which requires maintaining salt homeostasis, depletion of ATP, which requires prevention of mitochondrial injury and prevention of ROS formation and production of advanced glycated proteins, which requires restriction of constant supply of protein and energy to prevent formation of AGs. Now, hypertension works as a mechanical stress on this, and because of this, there are multiple common signaling pathways, especially increased angiotensin 2. They cause increased angiotensin 2, which eventually causes podocyte loss and renal and loss of renal function. The persistent increase in reactive oxygen species and reactive nitrogen species accompanied by a decrease in antioxidant activity leads to the occurrence of oxidative and nitrosative stress, which causes endothelial dysfunction, insulin resistance, alteration in the number and functions of pancreatic cells, and eventually leads to diabetic microvascular and macrovascular complications. So once ROS and RNS are produced in excess, they cause structural deterioration of macromolecules, leading to their instability and consequently loss of function. So in later stages of diabetic kidney disease, as GFR declines, both kidney and non-kidney related diabetic kidney disease complications develop, and predominant tubular interstitial disease is associated with damage to the peritubular interstitial cells that produce erythropoietin. Anemia and bone mineral metabolism disorders often develop earlier in diabetic kidney disease. In normoalbuminuric patients with diabetes mellitus, poor glycemic control is an independent predictor of progression to development of proteinuria and or ESRD, and hyperglycemia can leave an early imprint in cells of the vasculature and of target organs, favoring future development of complications. Now, nutritional intervention for good control of glycemia is therefore imperative. Now, landmark trials like DCCT and its follow-up epidemiology of diabetes intervention complications, United Kingdom prospective diabetes studies on patients with early stage of type 1 and type 2 diabetes have shown that intensive blood glucose control early in the course of disease, provided no further insults are imposed, exhibits a long-lasting favorable effect on the risk of development of CKD. Now, moving on to preventing progression of DKD. This requires multifaceted approach to intervention in diabetes and chronic kidney disease. So the goals of medical nutritional therapy here are to maintain near normal blood glucose levels by balancing food intake, exercise, reduction in albuminuria to less than 1 gram per deciliter, achieving optimal serum lipids, blood pressure, and reducing the risk of CVD, adequate energy intake to attain or maintain a reasonable body weight, prevent malnutrition, maintain nutritional status, and improve qualities of life through appropriate food choices and physical activity, achieve acceptable biochemical parameters and fluid status, and prevent and treat long-term complications. So the approved interventions for diabetic nephropathy are monitoring and treatment of glycemia, control of blood pressure, diet control, use of hypolipidemic agents, smoking cessation, and managing hyperuricemia. Now, maintaining of near normal blood glucose levels for glycemic control is fundamental to management of diabetic kidney disease for preventing progression and microvascular complications. Therefore, the target blood glucose levels should be fasting blood sugar less than 110 milligrams per deciliter, postprandial less than 180, and random less than 150 milligrams per deciliter. The DCC trial has shown that 1% reduction of HbA1c correlates with 35% reduction in the risk of complications, 37% reduction in microvascular complications, and 43% reduction in amputation or death from peripheral vascular disease. Now, the target HbA1c for these patients should be less than 7, irrespective of presence or absence of CKD in the diabetics. The Japanese study has shown that low serum albumin levels are associated with severity of microvascular complications such as nephropathy and retinopathy in diabetics. Therefore, correct hypoalbuminemia by improving protein and calorie intake and by correcting hydration status of the patients. Now, the component of diet which has greatest impact on management of blood glucose is carbohydrate intake. The most important issue here is how much in amounts and the type of carbohydrate in food influences blood glucose levels and when to consume it. So for patients who use diet alone to control blood glucose levels, they must emphasize on keeping the amount of carbohydrate relatively constant for each meal. They should have regular meal time, and insulin dose should be adjusted around the constant carbohydrate intake rather than carbohydrate being altered to meet the insulin regimens. Now, the Nutrition Subcommittee of British Diabetic Association has suggested that half or more of the energy content of the diet should be derived from carbohydrate. The overall aim is to reduce fat consumption to reduce the risk of cardiovascular disease in the long term. The glycemic control improves on a 60% carbohydrate diet, which provides at least 150 grams of fiber per day. Now, this paper published in Lancet has shown that a diet high in complex carbohydrate and leguminous fiber improves all aspects of diabetic control, and continued use of a low carbohydrate hydrate diet no longer appears justified. So leguminous seeds, lentils, and soybean produce only 22% to 40% of the blood glucose rise seen after consumption of the same amount of carbohydrate taken as whole meal bread. Soluble fiber of more than 25 grams from grains, vegetables, fruits, legumes, and nuts reduces total and LDL cholesterol. So if you have a look at this picture here, this is showing you slow digestion and absorption of energy dilute food in the fiber-rich diet, and consequently, the postprandial rise in blood glucose is slow. And here, however, you can see that rapid digestion and absorption of energy dense from low fiber diet food causes rapid high blood glucose. So, and this figure is showing you that there's a significant correlation between HbA1c and carbohydrate intake per day. So to control high postprandial blood glucose levels, use glycemic index of foods to fine-tune glycemic control. Now, there are certain special considerations in CKD stages 3 to 5 when we talk of glycemic control, because patients with decreased kidney function in stages 3 to 5 have increased risk of hypoglycemia for 2 reasons. One, decreased clearance of insulin and use of some of the oral hypoglycemic agents, and impaired kidney gluconeogenesis due to reduced kidney mass. So therefore, to prevent hypoglycemia in these patients, one has to give them small but frequent meals. They should not skip meals or snacks. Use slow energy releasing foods like corn beans for late night, corn and beans for late night snack. For whole fruit contain fiber and prevent hypoglycemia. Apples, guava, pear, berries, and grapes, and unsweetened canned fruits can be used, provided the patient's serum potassium is less than 5 milligrams per deciliter. Whole grain cereals, whole wheat, bread, pasta, brown rice, sprouted pulses, and legumes are, helpful in preventing hypoglycemia. But remember that if the patient gets into hyperphosphatemia, he has to be put on phosphate binders, and whole grain starches do prevent hypoglycemia. Now, DCC trial has shown that 25 kilocalories per kg body weight per day of energy intake should be enough. However, it can be increased to 35 kilocalories per kg body weight per day if required. So control energy intake in DKD as constant supply of energy and protein leads to the formation of AGs and increases proteinuria. Here you can see intensive control of blood glucose reduces urinary albumin excretion. And this also, the EDIC study has also shown that intensive control of blood sugar reduces proteinuria. Now, low protein diet has anti-fibrotic effect, it lowers hyperfiltration, retards onset of proteinuria and glomerulofibrosis, and ACE and ARB, ACE inhibitors and ARBs reduce degree of proteinuria in renal disease. And when low protein is combined with ACE inhibitors, additional antiproteinuric effect is observed. So protein intake in these patients should be 0.8 grams per kg body weight per day, and at least 50% of this protein should be of high biological value. As GFR declines, reduce protein intake to 0.6 grams per kg and prevent progression of diabetic kidney disease. Advise vegetarian, low protein diet along with keto analogs. Well, that will be very, very helpful, but you'll have to give keto analogs in a high dose. And the baseline, moving on to hypertension in these patients, we know that baseline systolic blood pressure of 140 millimeters of mercury in patients with diabetes has been associated with higher risk of ESRD and mortality. Though antihypertensive drugs slow progression of renal disease, but agents which lower systemic blood pressure without correcting glomerular hypertension do not usually ameliorate glomerular injury. For diabetics with CKD, target blood pressure should be 125 by 75 millimeters of mercury, and randomized controlled clinical trials on supplementation of soybean proteins have shown reduction in systolic and diastolic blood pressure in these patients. Now, renal artery stenosis is a recognized cause of secondary hypertension and renal dysfunction. Atherosclerotic renal artery stenosis is the most common cause of RAS, accounting for more than 90% of cases, and it increases with age, particularly diabetes, peripheral arterial disease, coronary artery disease, hypertension, and dyslipidemia. So control hyperlipidemia by reducing fat intake to less than 20 grams per day, limit saturated fats like red meat, whole milk, butter, and lard, avoid foods containing trans fatty acids, avoid hydrogenated vegetable oils, increase carbohydrate intake, preferably the unprocessed carbohydrates, and limit salt intake to less than 2.3 grams per day. JNC recommends less than 1.5 grams per day of sodium. Restrict salty processed foods, limit sugary foods, and increase fiber intake in the diet. Reduce dietary cholesterol to less than 200 milligrams per day, and restrict full fat dairy products and fatty meats and tropical oils like palm oil, palm kernel oil, and coconut oil. Now, dyslipidemia may increase albuminuria and accelerate progression of DKD and RAS. Substitute, therefore, grains and unsaturated fatty acids with fish, vegetables, legumes, and nuts. Introduce lifestyle changes such as 30 minutes walk 5 times a week to prevent atherosclerosis. Healthy diet, weight management is very, very important. The patients must avoid alcohol and smoking to reduce the risk and minimize stress. Now, we know that hyperkalemia is a known complication with RAS blockade and occurs in about 10% of outpatients and to 38% in hospitalized patients. Therefore, restrict potassium to less than 1 milliequal per kg per day, and stop vegetables and fruits which are high in potassium. Review concurrent drugs, consider diuretics, sodium bicarbonate therapy, and GI cation exchanges, and reduce dose, or you may have to stop ACE inhibitors or ARBs as a last resort. Now, prevent hyperphosphatemia, limit dietary phosphorus content intake to 800 to 1000 milligrams per day. Advise non-calcium-based phosphate binders, and calcium intake should be between 1000 to 1500 milligrams, both including the dietary and the supplementary calcium if the patient is on vitamin D supplements. Prefer plant protein. Highest load of phosphorus comes from protein-rich foods like nuts, hard cheeses, egg yolk, meat, poultry, and fish. And well, we know that metabolic acidosis is an independent risk factor for CKD progression. Therefore, sodium bicarbonate supplementation significantly slows progression of renal failure to ESRD and improves nutritional status in CKD stage 4 patients, particularly studies have shown about 27.5% of diabetics subjects do improve in their metabolic state. Now, comparable to sodium bicarbonate are the base-producing fruits and vegetables, which can correct metabolic acidosis without appreciable increase in serum potassium levels. Now, controlling inflammation is also very important. Low dose studies have shown that low dose pentoxifylline given to type 2 diabetes mellitus patients already maintained on losartan and enalapril to control proteinuria significantly decreases urinary albumin excretion from a baseline of 616 milligrams per day to 192 milligrams per day, and slows rate of GFR loss in stage 4 diabetic nephropathy on high dose. Now, NRF2 is emerging as a potential therapeutic target for diabetic nephropathy. It is adaptively activated in diabetic patients, but degree of activation is not sufficient to combat the oxidative stress aggravated by hyperglycemia. So non-toxic natural compounds can activate NRF2, and the things which our patients can actually take are some of the cruciferous vegetables, black tea, apple peels, cinnamon, curcumin from turmeric, and garlic. Now, use of vitamin D and its analogs may have potential as an adjuvant therapy for reducing albuminuria and slowing progression of diabetic nephropathy. Vitamin D receptor activator for albuminuria lowering trial, the VITAL trial, demonstrated a reduction in urine albumin excretion by 18%. So supplement vitamin D if deficient. Elevated albuminuria is a strong independent predictor of anemia. Albuminuria causes excessive urinary losses of iron, transferrin, erythropoietin, transcobalamin, and or other metals. About half of the diabetic patients with anemia have inadequate iron stores, and therefore correct iron profile with the folic acid, iron, and B12 and EPO supplementation. Now, dietary antioxidant vitamins such as vitamin A, C, and E detoxify free radicals directly and also interact with recycling processes to create reduced forms of vitamins. Hyperglycemia induces endothelial dysfunction through generation of oxidative stress. Therefore, combining antioxidant therapy like vitamin C with the normalization of glycemia can interrupt endothelial dysfunction. The study has shown supplementation of vitamin C in patients has really been very, very effective. And lastly, avoid greater injury to the patients by preventing volume depletion. Patients with any degree of renal failure presenting with a sudden deterioration from their baseline function should check for the possibility of volume depletion to prevent a decline in GFR. So the take-home message here is to educate patient on monitoring glycemia, treat hyperglycemia. Target blood pressure should be 125 by 75 millimeters of mercury for these patients. Control diet, advise lifestyle modifications for good control of weight, blood pressure, and glycemia. Correct dyslipidemia with diet and hypolipidemic agents. Advise smoking cessation, and advise self-management strategies to the patients. Advise timely adherence to medication. And thank you for your attention.